Welcome to our Adolescent Vaping for Pediatricians Prevention and Screening and Treatment program. I'm Michelle Dritz, and I'm going to be part of a panel of speakers this morning for our presentation. If you can advance the slide, please. One more time. So we have, like I said, a great panel of speakers today. First and foremost, we have Madeline and Ivy Smith, our teen experts. They are Ohio 4-H Healthy Living Advocacy advocates with the 4-H program. They create and present programs as well as with their fellow 4-H peers on addressing topics such as the opioid crisis, mental health, and teen vaping. They've been part of this program with us for a really long time and do an excellent job helping us as adults working with youth really understand the youth perspective. They know the power of peer-to-peer prevention and put it to good use in their communities. And they share a passion for promoting the 4-H, which is the health component of the 4-H program in their community. Our other speaker today is going to be Jengis Whitner. Jengis is an ambulatory care clinical pharmacist and a 340B program manager of Primary One Health in Columbus, Ohio. He received his graduate training at the University of Toledo and some postgraduate work at ProMedica Toledo and Ohio State University College of Pharmacy and Primary One. And then I'll be the fourth one joining our panel. And like I said, I'm Michelle Dritz. I'm an adolescent medicine physician down in the Dayton area. I work in primary care, those specialize in adolescent medicine. And we're all here to talk about adolescent vaping. So if you can go to the next slide, please. This is going to be what our agenda for the next 2 hours is going to look like. It's going to be a little bit of back and forth between our various presenters, and then we promise we will leave time at the end of everything for some opportunity for questions, but also feel free to continue to use the chat box as a great way to drive discussion and to answer questions. I'm going to start off though by handing things over to Madeline and Ivy for our myths versus facts pop quiz. So take it away, Madeline and Ivy.
Yeah. Hi everyone, I'm Madeline.
And I'm Ivy.
And we will be running your myth versus facts pop quiz today. So we do this with teens too. They always love it. It's always a fun one. So
we've taken this program to DC a couple years and all over Ohio. So if you want to go to the next slide. Yeah, one more. Okay.
All right, we're ready to get started. So I think how we're gonna do this today is, do we have the poll ready? Yes, so there will be a poll on your screen, and the first myth or fact is vape clouds are just water vapor, right? So go ahead and put in your answer. Yeah. It won't let us go. All right. Good job, you guys got that one right. So that is a myth, and from the time we started doing this presentation to now, consistently that one you guys have gotten that one right more often. I think in the beginning it was usually like a 50-50 split for that, especially with teens.
Yeah, definitely. Even now, teens still sometimes are like, oh, really? I honestly thought it
was just vape water.
All right, so if you want to go to the next slide, I don't know.
The next poll. So that on our screen looks like the same question. Yes.
All right.
So we will get the next question up in just a second. So it is not just water vapor, it is chemicals, and Dr. Dritz is going to go more into that later. But what's really dangerous is that we still don't know the effects of secondhand vape the way we know secondhand smoke. So
if the, sorry, you guys, this is Michelle again. So if the poll isn't working, why don't we just try advancing the slides, doing it that way? So Kristen, maybe if you can advance the slides, we'll go past that vape cloud. Yep, next one. And next one, and then here, I'll let you, Madeline and Ivy, take it from here. We'll just do it through the slides. Back up, Kristen.
All right, so thank you. The popcorn lung is a condition caused by eating too much popcorn. So you can go ahead and flip to the next slide now.
So this is one of our favorite questions to ask teens, because with it usually being such a dark presentation, this kind of gets everybody laughing, especially at the beginning of a presentation, and breaks the ice. But popcorn lung is not caused by eating too much popcorn. It's caused by inhaling diacetyl.
Here we go.
Yep,
okay,
here we go.
Got our polls. Awesome.
You guys can go ahead and click on your answer. Okay. Good job. So it looks like almost everyone voted for myth on that one. Like we said, popcorn lung is not caused by eating too much popcorn. It was named because we first found it. Oh, it was named because it was first found in a group of workers at a popcorn factory. So it is caused by inhaling diacetyl, which is a chemical used in vape flavoring, which is safe to ingest, but not safe to breathe in.
Yeah, so popcorn's not going to cause.
Yes.
All right, you can go ahead and flip to the next slide.
Okay, youth vaping is considered to be an epidemic. So is this a true statement or a false statement or a myth or fact? We're doing it today. Okay. Very good. So it looks like, once again, most of you got that right.
When we started doing this presentation, it was, I don't even know what year. It was a while ago, probably.
Early 2018.
Yeah, about that time. And
the answer to that question has since changed. So during a press conference on December 18th in 2019, U.S. Surgeon General Jerome M. Adams declared e-cigarette use among youth an epidemic. So it is considered an epidemic, and it is a very pressing problem for youth today.
teens who consistently vape won't need higher doses of nicotine to get the same effect.
I feel like we need the Jeopardy music when I do this. Very good. So, yes, that is a myth. Teens who consistently vape will build up a tolerance, and they will consistently need a higher dose to get the same effect.
So that's another thing that teens don't always recognize.
How easy it is to get addicted and how just doing it in a group of friends or at school can lead to bigger problems. All right, so teens who vape are more likely to smoke. Myth or fact?
Perfect.
Perfect. Teens who vape are 4 times more likely to start smoking, even though vaping was originally created to get adult smokers off cigarettes. It is now doing the opposite for teens. So teens are starting on vapes and then moving to cigarettes.
The majority of those who vape are adults, mainly former smokers. Myth or fact?
Okay, so for the first time, we have less than 95% of you split. So that is a myth. Teens are now outnumbering the amount of adults who are vaping. 1 in 5 teens say they have vaped, and teens are now consistently vaping more than adults.
Marijuana wax can be used in most vape pens.
Okay, so very good. Normally, this is the one that trips people up. Marijuana wax can be used in most vape pens. The difference is that when it's burned, it does not emit a smoke or a vapor, so it's really easy to hide that a teen is vaping.
Marijuana wax is incredibly difficult to extract and therefore harder to come by.
Very good. So that is a myth. Marijuana wax is much easier to come by than we would hope. There's actually YouTube videos teaching teens to extract their own marijuana wax at home with common household objects like a flat iron.
Right. Like just normal clothes iron, all kinds of stuff.
Yeah, anything you can heat up. The process of extracting the wax is dangerous and has led to explosions that have demolished homes. So while there are YouTube videos teaching teens how to do it, it's still not a safe process. It's even if they do complete it without demolishing their house, it's incredibly dangerous for them to have. A volley is a form of a flu virus. So that is a myth. A volley stands for e-cigarette and vaping. Oh no. E-cigarette or vaping product use related lung injury. So it is not a form of the flu virus, and it is a respiratory problem that can be very serious. And Dr. Dritz will talk more about that later.
Across the US, there have been only 64 reported cases of serious lung disease related to vaping.
Very good.
Yeah, that is definitely not the case. Yeah. Put that to the
Next slide.
It's almost 10 times that amount as of February 11th, 2020. The CDC reports that there have been 2,807 cases of serious illness and 64 deaths across the US that have been linked to vaping. So, of course, that number is
always changing. Only those vaping THC products are at risk for EVALI. Is this a myth or a fact? Very good. So, while many cases are related to THC products, there have also been cases reported where the patient has exclusively used nicotine. So the percentages are 82% patients reporting using THC products and 14% reported exclusively using nicotine.
Puff bars are the newest candy bar on the market.
Very good. Puff bars are not a candy bar. They are a disposable, single-use e-cigarette device, and they are not subject to the new federal policy regulating flavored e-cigarettes because they're disposable. So they have found a loophole to keep teens hooked on nicotine and vapes. But they do look like candy bars because that's their favorite. You know, we're not marketing to teens, but we're making it really easy to hide.
All right, well, thank you so much for playing that with us. We always enjoy doing that presentation, and we hope that you learned something new.
Great. Thank you, Madeline and Ivy, and for rolling with our early technology glitch. But thank you, everyone. Hopefully that kind of got your morning going as we continue to move on and talk a little bit more about vaping, EVALI, and COVID. I'll give sort of an update from a pediatric perspective. And then, like I said, we'll also talk a little bit more again with Madeline and Ivy about prevention and supporting healthy habits in the clinic. And then Jengus will finish up with talking about medical treatment options for dependence. Next slide, please. So we're going to talk some numbers and a little bit of a vaping primer. I don't want to spend too much time on that because for those of you who attended last year's annual meeting, Dr. McKnight did a great job of that in her hot topics section. I do want to talk about nicotine and specifically the effects that it can have on the developing brain, which is where our pediatric patients are, adolescents as well. We'll talk a little bit about EVALI again, sort of where the current landscape is, and then COVID and vaping too. So next slide, please. And the numbers mean a lot. They certainly mean a lot for the tobacco industry because they recognize that the earlier that they are able to hook someone on nicotine, the higher likelihood that they'll continue to be smokers into their adult adult years. And that was clearly what came out of the history of nicotine in the cigarette form, and we're seeing it now as they continue those tactics for vaping. Next slide, please. Though we had been seeing a really steady decline in tobacco use in the form of more traditional cigarettes over the past few decades, on the right-hand side, you'll see that very high increase pretty rapidly in use of nicotine in the form of vaping products. These 2019 numbers, which was the most recent one on this slide, was up to 27.5% of US high school students using vaping products in the past 30 days. Next slide, please. The 2020, though, National Youth Tobacco Survey data, so that same data you saw a moment ago, but now the 2020 data actually has shown some improvement in that number. For middle school students, we saw a drop in use from 10.5 to 4.7% from 2019 to 2020, that is using vaping products in the past month. In high school students, we also saw a drop from 27.5 to 19.6%. Some of this may be because we are actually getting through with the message about the perception of harm related to nicotine and vaping, and that it is not just water vapor, as Madeline and Ivy so clearly mentioned. Next slide, please. Unfortunately, though, what we are seeing in that 2020 data is an increase in those middle schoolers and high schoolers that are using really consistently. So for middle schoolers who are vaping 20 or more days a month, that number went up from, of those that were vaping at all, that number went up from 18 to 20%. And again, of those vaping and vaping more than 20 or more days a month, for high schoolers, that number went up from 34.2 to 38.9% in the 2020 data. Next slide, please. And it is a new normal, not just for COVID, but for vaping as well. As Madeline and Ivy mentioned, we're starting to see a shift from what was making up about 75% of the youth vaping market of being Juuls or pod-based type of vaping systems to disposable or other products. And this is some data coming out of the Truth Initiative's Adolescent nicotine cessation program, but it's now actually overcoming what youth are using, and they are now using other products other than Juul products a little bit more than they are Juuls, and puff bars make up a large portion of that, which, as Madeline and Ivy mentioned, are a disposable form of nicotine vaping devices. Next slide, or next click, please. Because I think this shows what we also are hearing from teens is that they now are recognizing that many of these nicotine products or many of these vaping products do contain nicotine, but that's in part what's driving them towards use, that buzz, that feel, but also that sense of coping, especially in a time when the stress and the life has changed really dramatically in a, unfortunately, really negative way for lots of our teens and adolescents. Next slide, please. We certainly see racial disparities when it comes to those youth, at least in the United States, who are vaping. For high school students, the majority tends to be white, non-Hispanic. Our middle school students, we see a little bit more of a shift towards Hispanic adolescents being the primary vapors in those years. Next slide, please. And this number seems a little non-believable, but really the tobacco industry is spending almost $1 million per hour on marketing tobacco products. And these were 2014 numbers. We've seen an increase in that, though I could not necessarily find you some specific numbers for data. But click through the next few clicks, because you'll see how that marketing is used. One more click, please. Both in the way that tobacco industries using social media and influencers, really targeting, just like they did often with traditional cigarettes, targeting certain minority and communities like African American communities, where we see far more tobacco advertisements in those neighborhoods, targeting LGBTQ communities as well. Unfortunately, playing a lot from their previous playbook in terms of how they market and how they hook. Next slide, please. So let's do that vaping primer that I was mentioning. Go to the next slide, please. When we talk about a vaping device, really what we're talking about is, instead of a plant-based type of nicotine, now they've extracted the nicotine and it's in a liquid form, and basically in an electronic device that includes a battery that is able to heat up a coil that then takes that liquefied nicotine and aerosolizes it, and that's what is inhaled by the user. Next slide, please. There's been, over the years, and by years I mean e-cigarettes in general, were created in the early 2000s in China, but there's been a change in what the vaping products look like over the years. We often describe them as generations, but they certainly initially started at things that look like and had the feel much like a traditional cigarette, but we've seen modifications to larger, what are like tank devices, to more of the pod systems. That's what a Juul would be a good example of. Soren pods as well, vape pens, as Madeline and Ivy had also kind of mentioned. And then one more click, because probably what would be considered the next generation, but we haven't called it that so far, are the disposables. Like I said, are pre-filled and pre-charged and ready for use immediately. Next slide, please. When we talk about the various vaping devices, just to give you a sense of the amount of nicotine and the cost per device, if you think of a pack of cigarettes as having 20 cigarettes within it and costing about $6, a Juul pod, so one of those single pods that go inside of a Juul device, also has the equivalence of a full pack of cigarettes of nicotine. And those pods themselves tend to run about $4. The device, the Juul device, usually is about $20 or $30. Those puff bars, the disposable cigarette or vaping products that we are seeing on the market now, also contain the equivalent of a full pack of cigarettes worth of nicotine. And you've probably been to a gas station recently where you can see even advertisements for those at usually 99 cents or less. So less than $1 for a single puff bar. The Fix and the Soren being two examples of other pod systems, bigger pods. And so they actually, the Fix pod is equivalent to 2 packs of cigarettes. The Soren pod is equivalent to 3 packs of cigarettes. So lots of nicotine in these devices in a really innocuous way. Next slide, please. As I mentioned, what's unique about vaping devices in general is we're still talking about tobacco-based nicotine, but in a liquid form. In the earlier forms of the vaping products, that liquid was what's described as freebase. Based upon what it was bound to, it tended to have a higher pH, and for those that were using it, would often be described as a little bit harsher tasting. Those would be the examples of the types of e-juice that's used in many of the tank or pod systems. The newer forms of vaping products, like the Juul, like the puff bar, like those pod systems, use what's described as a nicotine salt, which is just another, using different chemicals to bind to the nicotine, ends up causing a lower pH and a much less harsher tasting, and higher nicotine per puff concentrations with much more lung absorption. So oftentimes teens or adults who are using them don't even necessarily appreciate just how much nicotine they're getting per puff. In addition, the way a vapor uses their device, how deep of an inhalation, how much liquid they're using, the concentration of the e-liquid that they may be using or filling it with, can also really start to differentiate the bioavailability of nicotine per puff. Next slide, please. There is certainly much more than nicotine in many of these vaping devices, including things like humectants, which help, like I said, are part of what helps carry the nicotine compound and reduce moisture loss, but the toxins that go into the flavorings, the particulate matter that is often given off from the heating element itself, many things that we know in and of themselves, or once they're heated in the form that happens as you aerosolize that solution, give off chemicals and toxins that are known to produce lung inflammation and lung injury, similar to what Madeline and Ivy were describing with just one of those, in particular with the popcorn lung description, as well as known carcinogens and formaldehyde, otherwise used in embalming equipment. I mean, these are the types of toxins that we're seeing are part of the aerosolized solutions that anyone who's vaping is inhaling, and in some cases often given off in secondhand and third-hand ways. There are also ways that users can add other psychoactive ingredients like THC, either in a prepackaged form or making it on their own. So this is certainly not just water vapor that we're talking about. Next slide, please. And as Madeline and Ivy mentioned, adolescents in particular who vape are 4 times more likely to move on to smoking cigarettes. And actually, with a really great hot topics yesterday, Dr. Kemper mentioned an even newer study that shows that actually it's the teens that had no intent to move on to cigarettes that had an even higher risk of moving on to traditional cigarettes at almost 5 times the amount. We see adolescents who vape are also more likely to move on to marijuana or binge drinking or other illicit drugs. And some of that may have to do with other risk factors involved in that adolescent's life that make them more likely to use other substances, whether it's untreated mood disorders or ADD, or adverse childhood experiences, stressors, things like that. But there also seems to be sort of a biological priming effect that nicotine has on the brain that potentiates the effects of those subsequent drugs, and therefore may make it more likely that they go on to use or continue to use. Next slide, please. Just to touch a little bit on vaping THC, because that's definitely one of the things that adolescents are using in those vape products. As Madeline and Ivy mentioned, it's pretty easy to get THC to be able to use in their vape product. It's actually often a concentrated form of marijuana or marijuana resin or wax, as they were sort of describing, that's used in the vaping devices. And really, that's the dabbing process that they're talking about, sort of really using that heating element to aerosolize that marijuana use. And we're seeing 12th graders, again, an increase in trend of use of THC in their vaping products, with 12th graders from 2018 to 2019 moving up to almost 24% of high school or of 12th graders using THC. And we're talking about not just THC in the maybe percentages we think about in the plant form, where in the early 90s, those were usually containing about 3 to 4% of THC, now more about 13 to 14%. But in the marijuana concentrates, those are often THC's levels of 40 to 80%, with a much greater pharmacodynamic effect and higher concentrations that are ending in the blood compared to equally smoked doses with the plant-based cannabis. Next slide, please. So let's talk about nicotine on the body and the developing brain. Next slide, please. Well, like we said, for vaping devices, it is certainly the primary psychoactive ingredient in those vaping devices, and certainly in all of the pod-based systems and the disposable systems like Puff Bar. That nicotine goes to the brain within 6 seconds after that first inhalation, and occupies 50% of those nicotinic acetylcholine receptors in the brain within 1 to 2 puffs. And as we mentioned, there are ways that smokers can use their device or modify their device to control a little bit how much of that nicotine level is getting in. Next slide, please. We have lots and lots of history and data on showing the physical effects of nicotine on the cardiovascular system and the GI system and the central nervous system, lungs, so forth. But next slide, please. We also have lots of evidence and history on showing just how addictive nicotine is, especially even in comparison to the things that I think we and the lay person also thinks of as addictive in terms of cocaine and heroin. Next slide, please. And that addictive property of nicotine comes in part from the fact in how it imitates the effect of acetylcholine on brain neurons and causes dopamine release in that limbic system, really activating that reward circuitry in the brain. Next slide, please. For nicotine, certainly, and addiction in general, it manifests in a few ways, part of which is the physical addiction. As Madeline and Ivy had mentioned, we can see tolerance developing at even higher levels with our adolescents. We see withdrawal, how that occurs, requiring redosing that in order for the person to hopefully prevent those withdrawal symptoms. There's also an emotional component to that addiction, as it gives them a sense of well-being and helps boost mood. For some, they'll often describe stimulating memory or alertness. Others may be using it because of a sense of decrease in appetite. And there's certainly a behavioral addiction that we see with youth as well as adult, especially as it's reinforced by social cues and the way they're using with friends or in certain environments and the habits that get formed because of it. Next slide, please. With adolescence, in that still developing brain, which is still going through development up until about the mid-20s, we see nicotine's effect being one where the brain is more sensitive to those addictive properties of nicotine. We see dependence at lower levels of nicotine use in our adolescents, and in the most susceptible cohort of those patients, sometimes within 1 to 2 days of first use. We also see higher risk of withdrawal symptoms in adolescents with lower use. Again, in our most susceptible adolescents, they may be noticing withdrawal symptoms before even reaching a level of 2 cigarettes a day. And if you remember, a single Juul pod or a single puff bar is equivalent to 20 cigarettes a day. This is less than 1 Juul pod a week. This is less than 1 puff bar a week, and already potentially having physical addiction symptoms with it. Next slide, please. Part of what also seems to be unique about the way nicotine affects the brain, and especially the adolescent brain, is its effect on short and long-term brain receptor modulation, including both for the nicotinic acetylcholine receptor and glutamate receptors. And some of these receptor modifications or modulations that we see in the teen brains, even more so in adult brains, can be short acting, but some of them are quite long acting, and leads to some of the clinical findings that we see in terms of increased cognitive impairment, particularly later in life, increased risk for some in developing certain psychiatric disorders, and increase in attention deficit issues that may increase with years of use. Next slide, please. So unfortunately, I think the tobacco industry and the vaping industry really is stacking the deck against youth, similar in ways that they've done this in the past. But as Madeline and Ivy also mentioned, it's a very, a lot of marketing that goes into flavors and things that very much are targeting sort of what youth tend to enjoy. There is a plethora of advertisement in all shapes and forms, and the vast majority of US middle schoolers and high school are being touched by those advertisements in some fashion or another. And nicotine in particular, once they're hooked, is very hard to stop. And hopefully I've left you with a sense of how that nicotine can be potential or even more potentially dangerous in that still developing brain of an adolescent. Next slide, please. So let's talk a little bit before I end here about EVALI and COVID. And let's remember EVALI, because I know that's sort of shifted off of our brains for a little bit, but it certainly still is there, and it's certainly something that we want to continue to remember. Next slide, please. EVALI, as Madeline and Ivy mentioned, is short for e-cigarette or vaping product use associated lung injury or illness. As of February 18th, 2020, that's the last CDC website data, there have been over 2,800 cases and almost 70 deaths, a large portion of which are in our young adult and adolescent population. All of the patients reported some form of e-cigarette or vape use in the past 90 days. That's a hallmark in part of the diagnosis. And as Madeline and Ivy mentioned, there was certainly a higher percentage coming from THC product use, in particular, oftentimes more informal THC products from sort of non-regulated, quote unquote, regulated sources, but still a portion that seemed to only be using nicotine products. We have seen a decline in cases, at least from the numbers, since the peak in September of 2019. But like I mentioned, adolescents make up, adolescents and young adults certainly make up a large portion of the cases in general, with a shift towards males, a higher likelihood of diagnosis in adolescents who had ADHD, had mental or emotional behavioral disorders, or even a history of asthma. For those of you who may have seen patients with EVALI or remember some of the medical symptoms that we can see with it include respiratory and constitutional symptoms in particular, also GI symptoms, and almost 50% of patients with EVALI were needing some form of ICU care, and almost a quarter requiring mechanical ventilation. Next slide, please. At this point, the CDC, based upon the research that's come out, is feeling that certainly a large component of the likely reason for the EVALI outbreaks that we were seeing was related to vitamin E acetate that seemed to be added to some of the THC containing vaping products, almost to cut the THC liquid in a way that sort of gave it the same viscosity. That seemed to be strongly linked to most of the cases. And that vitamin E acetate, though it seems like it wouldn't necessarily be a problem since the FDA has approved it for oral and topical use. This is a great example of how something that may be quote unquote natural or otherwise safe or okay in one circumstances certainly does not make it safe or okay in others. Because when vitamin E is heated and inhaled, that's where we see that risk for lung injury because of its lipid properties, its way in which it seems to disrupt the ability of the lungs to inflate, especially also because of the temperatures which are needed to really be able to heat it up, to vaporize it, leading likely to be a part of the reason why we see the types of lung injuries that we do with EVALI. Next slide, please. So from a CDC perspective, there's still guidance about how to diagnose either a confirmed versus a probable case. But again, the hallmark is the recognition that they've used some sort of vaping device in the past 90 days and that they have evidence of pulmonary infiltrates, but really no other obvious source of what's causing the clinical situation that they're having. If you go to the next slide, please, you'll be able to find on the CDC website the current algorithm for management of EVALI, which is primarily supportive at this point, may or may not include corticosteroids depending on the severity of their symptoms. But at this point, again, is primarily supportive in nature. Next slide, please. Last thing I want to touch on is COVID and vaping. What we know and what we still don't know. Next slide, please. So what we are starting to know is that adolescents, especially adolescents who vape, have a higher risk for COVID-19. For adolescents who have vaped or smoked in the past month, they were 5 times more likely to describe COVID-19 symptoms. And for adolescents who have ever vaped, they were 5 times more likely to be diagnosed with COVID-19. And if they vaped and smoked in the past month, they were almost 7 times more likely to have been diagnosed with COVID-19. So if you click again, please, you'll see that vaping and smoking is probably one of the single most modifiable risk factors. Our adolescents and even adults who vape or smoke have an ability to control to reduce their risk for severe COVID-19 infection. Next slide, please. Why do we see potentially this connection between the SARS-CoV-2 virus and vaping or smoking? Well, in part, what it's related to is the ACE2 receptor. The SARS-CoV-2 virus uses the ACE2 receptor to bind and enter cells, and smoking and vaping seems to upregulate those ACE2 receptor gene expressions. So we see higher levels of ACE2 receptors throughout cells in our body, but in general, even in higher percentages in certain cells, like in our lungs and small intestines and vascular endothelial cells. We know the SARS-CoV-2 virus causes pulmonary abnormalities and pulmonary involvement, and causes a variety of issues for the immune system, including some decrease in innate immune response, but also an increase in inflammatory molecule production. And vaping and smoking sort of goes against a lot of making it harder for the body to fight off those infections as well, because what vaping and smoking tends to do from a lung perspective is increase cellular toxicity and impair that gas exchange already, and decrease cough sensitivity and poor ciliary dysfunction, making it harder to clear those infections. And vaping and smoking also cause problems with our immune system and its ability to really fight infections properly by downregulating some immune system genes and impairing neutrophil phagocytosis and macrophage function. There's also probably some unique transmission risk when it comes to thinking about vaping and SARS-CoV-2 and the connection as we think about especially our adolescents sharing vape devices and transmission in those ways. And certainly probably not using masks or social distancing when used, though I've seen pictures of people vaping with masks on. So a connection to be thinking about and talking about with our patients as well. Next slide, please. So, you know, I want to leave you with one of my favorite quotes from the Truth Initiative. When it comes to vaping, it may be safer in some respects than traditional cigarettes. That's certainly what the media would like us to think, but it certainly doesn't mean it's safe. And that's one of the important messages we need to continue to make sure that we're talking with families and teens and adolescents with. So next slide. What's a pediatrician to do? So we're going to shift gears a little bit here. If you can go to the next slide, please. We're going to start talking about vaping prevention and supporting those healthy habits with adolescents in our clinic. And I'm going to start it off, but then Madeline and Ivy are going to join us partway through this part as well. So next slide, please. Next slide. So, you know, I want to remind us, we talked a little bit about nicotine and the adolescent brain a little while ago, but adolescence in general is a time of heightened exploration and novelty seeking. And it's in part developmentally appropriate because it's also a time in life where we need to gain experiences to be prepared for and to be able to do more complex adult decision makings as we transition to adulthood. There's a lot of skill development involved in it. And those habits that we're laying down in adolescence really form the foundation for adult health. Next slide, please. There is lots and lots of development that's happening during these adolescent years, including physical, but also a lot of psychological and cognitive and social development. And I don't mean to use this picture to suggest that that's the size of a teen brain, but there is lots. I just want to show the idea that there's lots of growth going on, even if it's down at the cellular level. Next slide, please. Particularly when it comes to brain development, though, in adolescence, we still see two really important areas still undergoing development, including the frontal lobe, which is responsible for personality and judgment and reasoning and problem solving. That area undergoes still a significant amount of change during adolescence. It is not fully developed until about the mid-20s. That's why you see us talking about adolescent brain development often until about the mid-20s. Next slide, please. A little deeper down in the brain towards those temporal lobe regions, we see a lot of growth still happening with the amygdala and the hippocampus, and really areas where there's a lot of control over information sorting and short-term memory and emotional regulation. And this area of the brain seems to mature a little bit faster, reaching its maturation more around the late teens, 18 or 19. Next slide, please. What leads, though, in part, as we just think about these two particular areas of the brain, some of the unique ways in which adolescents behave and act during these years is in part because of the still development, but also mismatch a little bit in terms of where the developmental trajectory is for these various regions of the brain, the prefrontal versus the limbic. And so we see this sort of unique time during adolescence where those emotionally heightened situations in particular are sort of overriding the prefrontal control systems, because that limbic system is a little bit further along in its development than those prefrontal cortex. Even for teens that know the information, that sort of understand the risks academically, the intensity of that emotional context may bias them towards behaviors that really go against those risks, really go against their knowledge. And that combination of heightened response to rewards and immaturity of those behavioral controls can often end up biasing adolescents to seek that immediate rather than long-term gains, explaining at least to some part why we may see some of those increase in risky decision making during these adolescent years. Next slide, please. But problem-free is not fully prepared when it comes to adolescence, because like I said, it really is an important time for exploration and for learning as you go in order to be able to grow and learn how to make a lot of those more complex decision processing. So next slide, please. That just means a lot of what goes into supporting teens to thrive is allowing for that really important developmentally appropriate exploration and experience gaining, coupled with adults who work with youth, adults that care for youth, to really give them the important structure and safety that they need during that time in life. It's not unlike those toddler years where we're very, I think, understanding and willing to recognize that those toddlers really need to be out and exploring and seeing the world, and they're moving all over the place. And we don't stop them from doing that. We don't put them in a bubble, but we create those safeguards around them, like putting the covers on electric outlets, or putting those stairs up at or that gate up the stairs so that we can create a safe environment for that important exploration. The same goes true for adolescents. Just what those safeguards are may look different, and what that education and anticipatory guidance is may look different as well. There are lots of opportunities that we have to reduce some of those negative outcomes by really building up protective factors. Some of those protective factors being around bolstering community and caring adult connectiveness, helping to build healthy coping tools and resiliency, and modeling those skills as well. We know there's a really important role in terms of certain effective parenting styles, especially around authoritative type of parenting, that is a great balance of both really strong limits, but also really strong emotional support. And there are certainly a lot of both physical and emotional supports that we can do at the community level and at the advocacy level and legislative level to help create those safeguards, especially around nicotine and vaping, like tobacco 21 laws and marketing limitations and school policies and things like that. Next slide, please. So let's talk about vaping now as we move out of just adolescent brain development. Next slide, please. There are lots of ways in the clinic where you may already be screening for and talking about youth substance use, not just vaping or nicotine, but youth substance use in general. Maybe it's the CRAFT screening tool, maybe it's the S2BI. There's quite a few different screening tools out there as a way to identify patients. And in their best form, they're coupled with clinic-based brief counseling or intervention in some way and referral if needed. Next slide, please. Some examples as I was mentioning there. Next slide, please. Are the CRAFT and the CRAFT tool, which has historically been used for alcohol use and other drug use, has recently been revamped to add on some questioning around nicotine use in particular, and screening to help with identifying nicotine dependence, which we'll talk about in a moment. But here you can see two of the maybe more common tools that are used in our pediatric settings and their scoring criteria, just to really get a sense of use and identifying potential problematic use of many substances in some of these, including tobacco use. Next slide, please. But regardless of what our setting is or what screening tools we may or may not be using, it's important that we continue to ask teens about nicotine use and vaping use, to listen to their stories, to be able to answer some of their questions and support those youth in learning the skills to be healthy, resilient, successful adults. And if we don't know the answers, or if we feel outside of our comfort level, we need to know where to be asking for help. Next slide, please. So why do teens vape? And I'm going to pass things on to Madeline and Ivy to take over this part.
Okay, so why do teens vape? We have put together this presentation for you guys based on information we've gathered from talking to teens, from presenting for teens, and how we connect with them. So
yeah. So we like to end every one of our teen presentations with asking them why they've heard from their friends or possibly considered it themselves.
And this is some of the things we know from them and just what we know about talking to other teens, what we know about ourselves. So we are often still too young to be thinking about long-term consequences, yet old enough to believe we know what's best. We're at a stage in our lives where we're making really big decisions all the time. We are asked to think about college and choosing a major and what do we want to do as a career and who we're going to date. And it involves taking risks. So we're still at a stage where jumping off a cliff feels more like an adventure because we're not understanding the pain of the potential fall. So for something like vaping or substance abuse, a lot of teens are still seeing it as something that can't hurt them and playing into that kind of invincibility complex that a lot of teens have.
Also, like, you know, they try it with their friends and then they're like, oh, well, that made me feel better. Now I'm gonna keep doing it. All right, you can go to the next slide. All right, so peer pressure. Obviously, this is something that we talk about a lot when we are discussing anything involving teens. And even, you know, tweens, that younger group as well, it's just as prominent there. So
now with YouTube and social media, TikTok, Pinterest, all the social media platforms, peer pressure has exponentially increased in this generation, and it is 10 times more powerful than it ever was. And
but that, like, being with your friends peer pressure is also still there. Obviously not as prominent at the moment, but
we'll get back there.
Yeah. it's still there, and you know, they don't want to be like that person that stands up and is like, no, I'm not going to do that.
The good news is that peer pressure works in a positive way too. So when we do peer-to-peer prevention, and when teens have good role models, the same peer pressure to be the one that is doing all the good things is still there, and it still can work in our benefit. Go ahead and go to the next slide.
All right, so this is a slide of some of the responses that we've got into the question, why have you heard that your friends vape or consider doing it yourself? So it's safer than smoking. At least I'm not doing that. That's a really,
really common one, and it usually changes by the end of the presentation.
Yeah, and that's always the, like, it always comes with that second part. At least I'm not doing that. Like, it could be worse. So
yeah, so like, get off my back. At least I'm not. And you know, to that I say, well, at least you're not sticking your foot in a bear trap, but let's stop doing dangerous things. It tastes good.
Yeah.
Obviously this has changed a little bit as federal policies have regulated flavoring of vape, but puff bars and companies finding loopholes are still around.
I only do it when I'm around my friends. Well, I'm glad you're not doing it more, but
it's still dangerous.
It's still dangerous, and it is going to lead to you doing it not just with your friends.
I didn't think it could hurt me. That's another one that will usually, by the end of the presentation, be like, oh, well, advertising led me to believe that it was safe.
It's just water vapor, like we talked about earlier. You know, a lot of teens do believe that. Obviously, that's getting a lot less common. There's a lot more conversation around this topic now, so that one's getting a lot less common now. But teens, they tend to feel like we're not like you're attacking them when you're asking them this question, like accusing them of doing it. And
that's definitely not what we want to do. We know teens can get defensive, and that ends trust and relationship when then they'll hide things. And this is already something that's so easy to hide. So talking to them in a way that is non-judgmental and is simply there to educate them and tell them the risks gets a lot better results. And then they end up asking us questions or trying to understand better than when we're like, stop, because no one wants to be told what to do, especially at this age.
All right, you can go to the next slide.
So okay. What does work? How do we talk to teens?
Go ahead and flip that again. So peer-to-peer prevention. This is a huge part of 4-H. So in 4-H, we like to do as much as possible through peer-to-peer prevention. Teens, they don't want to be told, even younger kids, nobody really wants to be told what to do.
No. It's like if you've ever sent your kid to summer camp and you can't get them to clean their room, but they absolutely love that cleanest cabin competition, and they have cleaned their cabin and made their bed every day all summer. It's because their counselor, their older teen mentor, told them that that was the best thing to do. They like to listen to other teens. They see them as helpful, as positive role models, as someone that is cool, much rather than an adult who is just telling them.
Even if that teen is telling them to do it, it's more of like a suggestion from your peer than an order or something like that. So that's a big thing that we
promote in 4-H, and we have programs for peer-to-peer prevention that we take into schools and 4-H events. And, you know, like we said, peer-to-peer prevention is all around 4-H, even outside of just a healthy living standpoint, in that we believe positive role models and positive groups of youth are the best thing for us.
Always like to have teen leaders in all of our programs.
Yep.
All right, you can go to the next slide. Keep it short. Teens have a very short attention span. The average 15-year-old's attention span is 8 seconds. A goldfish has an attention span of 9 seconds. So if a teen is engaged, they can focus on a task for about 45 minutes. those first 8 seconds, it's necessary to get their attention and hold on to it, or they're going to zone out and not pay attention to you at all the rest of the time you're talking. So
some of the ways we like to do this are like that myth versus fact thing we did with you guys at the beginning of this presentation. When we're doing it in person, we have teens stand up and sit down or go to opposite sides of the room so they're moving. The best attention grabber we've ever done is our Vape Busters skit, which we promise to do as soon as we're able to see you all in person. It was a spoof on Ghostbusters.
Yeah, we did it at the National 4-H Healthy Living Summit in Washington, D.C. And
it was a 1-minute skit that made the point and kept everyone engaged for the rest of our presentation.
And then later that week, we had our like more in-depth presentation that they could choose to come to. They had like lots of sessions that they could attend, and that
was an incredible
1 minute that we had to start really made them engaged in our topic and want to come to our session. So grabbing their attention, getting something maybe a little bit lighter to start your...
Don't be afraid to have fun with it. And even though it's a very serious topic, to get everyone laughing and break the ice. You can go ahead and switch the slides.
The power to choose. So teens, like we said, don't want to be told they can't do something. It's like when you have a box and you're like, don't look in that box. Before you didn't think about looking in that box, but now it's all that you want to do.
Mm-hmm. So instead of telling teens don't vape, because now the only thing they want to do is vape, we should be telling them the consequences of vaping. So giving them all the information and helping them make that informed decision. Like we said, a lot of why we're hearing teens are vaping is because they don't know the consequences. They don't know the dangers. They don't understand what it is. So they perceive it as something that is safe and not hurting themselves or anyone around them. The Real Cost and My Life, My Quit are two programs that we really love and that we find really helpful, and we incorporate them into our presentations.
The Real Cost, they have a lot of really short commercials and messages that get the point across in a way that's not telling teens don't do that, but telling them that there are consequences, and in a really short, to the point way that holds their attention. All right, you can go to the next slide.
Okay, thank you all. We'll turn it back over to Dr. Dritz.
Great, thank you, Madeline and Ivy. So jumping off from where Madeline and Ivy just was able to kind of fill us in from a teen expert perspective, I want to talk a little bit about creating that structure for support in our clinics. So next slide, please. So, whatever the topic may be, when it comes to risk behaviors, there often is useful to think about it in terms of a framework for those conversations. Some sort of screening, whether it be a really formal type of screening tool that's being used, but based upon that screening process, moving on to hopefully some sort of brief intervention and treatment, whether it be referral or treatment that can be done within your clinic setting, to really create the supports around the risk behavior that we're worried about. Next slide, please. That framework is really very similar, whether we use the term SBIRT or motivational interviewing or 5As or chain talk. It's really just reminding us the importance of when we're having conversations with patients, especially when we're having conversations with adolescents, as Madeline and Ivy mentioned, that this is a conversation, not a I'm telling you everything and you're listening to me type of conversation. It is a sort of two-way street that needs to also be hopefully surrounded with support to help teens wherever they are in moving them hopefully towards healthy, positive behavior change. Next slide, please. There in our clinic settings, there are lots of ways that we can certainly get this conversation started, and it starts with the things that we do even before we start the conversation. It's fostering that safe space to talk, creating those adolescent friendly environments, making confidential time routine with our adolescent patients, starting in early adolescence. 12, 13, 11, there's going to be different ages in which different clinics will do this, but starting early adolescence is important. The way we build rapport with our patients as we're creating time to check in with them in their lives during the clinic visiting, really shifting our focus during those clinic visits from the way we're used to maybe focusing on the parent during the younger types of childhood visits to now the teen being our main focus, and the parent or the guardian that's with them is really their support person. And using those conversations as a time not just to assess for risks, but to explore strengths and goals and support networks and resiliency skills in a way that helps us develop an understanding of what matters to them and where their supports are. And there are lots of great tools in order to help sort of guide clinicians during these conversations, but the heads or the shade psychosocial assessments are just 2 examples. Next slide, please. Again, whether we're using a really formal substance use screening tool or just incorporating questions in our conversations about adolescent vaping, we find and we hear from other adolescents that some strategies that may be helpful is thinking about it a little bit in terms of where they are in their developmental stage. So for our earlier adolescents, oftentimes starting those conversations when you get to the point where you're talking about nicotine use or vaping, asking about what their friends may be doing or what they've noticed in their schools or their groups in which they hang out with, and then moving on to asking about their own use. For later adolescents, it may be easier to just right off the bat start with those conversations and questions around their own use, but certainly exploring what their friends groups are doing and what is around them from a social perspective. And then moving into questions, if they are using, about possible dependence. Is it difficult for them to forego needing to have a vape or feeling like they need to reach for their vape every day? Asking how it's going in terms of dealing with peer pressure, as Madeline and Ivy had mentioned, and really promoting some of the social norming around the positive behaviors that are going on around them as well is really helpful in those conversations. Next slide, please. There are really opportunities everywhere for us to continue to support and really celebrate the healthy, positive behaviors that adolescents are making every day. So when you're having conversations with teens and they're telling you that they haven't vaped, really congratulate them. Take the time to stop and congratulate them for their healthy choices. Ask them about how they are navigating pressure. It's a great opportunity to reiterate some of the risks that we've talked about today around nicotine, especially during these years, and about vaping in particular as well. And then emphasize prevention, because that really, as a pediatrician, is probably going to be our strongest medicine when it comes to reducing the risk for nicotine addiction and long-term use. Next slide, please. If an adolescent tells you that they have vaped, then listen to their story. Find out during the conversation what they're using, what types of devices they're using. Are they using flavors? Are they using nicotine? Do they even recognize if they're using nicotine? Are there other substances that they're using with their vaping devices? Finding out when they're using, how often, has it changed over time, why they're using, what's the context in which they're using, with friends, is it social, is it on their own, is it to help deal with stress or mental health concerns? concerns? Is it curiosity based? And start asking questions based upon the answers to those other ones about experiences where maybe they've tried to stop, or what they perceive as the benefits, or what they perceive as really the things that they're worried about, or risks. So you have a good sense of where they're coming from as you continue that conversation about trying to help move them towards healthy, positive health behaviors. Next slide, please. The goals of those conversations, though, as I've been describing, is really to understand their use, understand their motivation for using, build on what their knowledge already is to support those informed decisions, and understand and foster their readiness for change. Next slide, please. Because even though many of us, I'm sure, are aware of and understand this idea of readiness for change, anywhere from pre-contemplation, not even thinking about stopping vaping, to ready for action, or maybe even in that maintenance phase, regardless of where a patient is in this stage of readiness, what we always have an opportunity to do during our time with them is to help move them along in this stage of readiness. So it's not always about what we're doing for the patient who's in the action phase and ready, but how we're moving them along with each subsequent conversation and opportunity that we have to meet with them. Next slide, please. There are many, as we mentioned before, change talk and skills and concepts that help us have hopefully more effective conversations with patients in the clinic, including ORs and rule, basically mnemonics to help us remember those ideas of using things like open-ended questions and understanding their motivation and avoiding argument and rolling with resistance, expressing empathy. It's really just, again, tools that help remind us how to be able to have more effective conversations with our adolescents, with all patients, but I think particularly useful when we think about those conversations with adolescent patients. Next slide, please. But all along the way, we want to remember that really what we're trying to do is support positive behavior change. So again, regardless of where they are in that cycle of readiness, we need to sort of understand where they are and help support them wherever they are as we're trying to help move them further along in those stages of readiness. Be ready to congratulate and reinforce those healthy behaviors that they're already engaging in, but be clear also about helping give them information for those informed decisions so they understand what the risks are. And certainly, at least from your perspective, the importance of why you worry about their health when they're engaging in those substances, and your goal, hopefully in one day, and trying to get them to stop and certainly cut down in the meantime. We want to help reinforce the autonomy in developing of the skills for independence. And I think Madeline and Ivy have mentioned that if we don't do that, we're actually probably shooting ourselves in the foot in terms of those conversations. But I think there's ways that we as clinicians can really be partners with adolescents during these conversations in a way that in the long term really helps move them towards more positive, healthy behavior changes and help prepare them with the skill development for other risks that may come up in their life, nicotine just being the example that we're talking about right now. Next slide, please. When we are having those conversations about behavior change for those patients that are vaping, those conversations really should be very patient-directed, patient-oriented. Sometimes our goal is around harm reduction. It may not always be able to be quitting at that moment in time. Those small steps do count as we're really trying to build self-efficacy or build their own confidence in their ability to set goals and be able to achieve them. Next slide, please. So again, in the clinic setting, we have really opportunities to help us with these conversations by building those one-on-one times of confidential conversation, ideally in any opportunity that we have with a teen in the clinic. So not missing any chances, since we don't often see them in the clinic as often as they probably even need to be, but really creating that safe space that gives them an opportunity to voice their thoughts, their concerns, and to allow us to really explore their personal strengths, their supports, their resiliency skills, so we can help them help themselves. And luckily, what I think we also have the opportunity to do is to support them with immediate medical management options if necessary, especially around dependence, which in just a few minutes I'm going to have Cengiz talk about a little bit more as well. Next slide, please. There's lots of ways this conversation may look, and sometimes it's just about getting out and practicing them a little bit more. On the Ohio AAP website, there is a plethora of resources around specifically adolescent vaping, including some sort of examples of how some of those conversations may go, and some ideas in terms of some responses that you could use during those conversations in the clinic. Next slide, please. One of the important things as we think about being a pediatrician in the clinic with our adolescent who may be vaping is the importance now, especially, of assessing dependence, since we're seeing really a surge or an increase in that more consistent use, and recognizing the increased risk for nicotine addiction with that developing brain. Considering those pharmacological treatments, but ideally coupled with behavioral support services. So next slide, please. Again, when we talk about nicotine dependence or withdrawal, those are symptoms that we can see occurring within hours, sometimes, of last cigarette or vaping use. And they usually may present with signs suggestive of withdrawal symptoms that can occur within, like I said, just a few days, though can subside within a few weeks. Those may have physical symptoms associated with it or psychological symptoms that are associated with it. And if you go to the next slide, please. There are a few more recently out tools that providers can use. Next slide, please. That help us as clinicians be able to evaluate dependence risk, specifically for adolescents with vaping. The Promise E is one such tool. There's no sort of absolute cutoffs, but the idea here is to take the average of the items scored. And Cengiz will talk about this in a moment. If you go to the next slide as well, though, as I mentioned earlier, that CRAFT screening tool has been updated. Now you'll find an additional tool on the CRAFT website, which is free to use, called the CRAFT 2.1 plus N. That's basically the nicotine dependence scale that goes along with it. It's based on the Hook on Nicotine checklist. And again, it also doesn't have a specific cutoff, but the idea is that this is a sort of a continuous scale to get a sense of basically symptoms suggested nicotine dependence. Next slide, please. Cengiz is going to talk exclusively about medication support for cessation, nicotine cessation, including nicotine replacement therapy and neuromodulators. But I wanted to sort of put things together all on one snapshot slide so that you can see and be able to refer to it in the clinic if you need to. And if you click again, I just want to remind us as clinicians that as we are often thinking about the best treatments for adolescents who may be vaping, and especially vaping with evidence of dependence, we often want to remember what those underlying conditions that may be really influencing why they're using to begin with, and addressing those underlying issues, whether it be anxiety or depression or ADHD or poor coping skills. So the way that we're treating the patient as a whole may be much more elaborate than simply thinking about what we're using to help with their nicotine cessation. Next slide, please. Ivy and Madeline mentioned a few quit resources that like the My Life, My Quit, but that one is through the the national quit line, but with the Ohio quit line as well, has that My Life, My Quit, which is an option for adolescents. Another big one that's used by a lot of young adults and adolescents is the Truth Initiative's This Is Quitting, which is a text or app-based system. And you can see information for links to all of these types of quit resources that are very specifically targeted for adolescents and young adults. Next slide, please. But regardless, again, of sort of everything that we've talked about before, we want to remember that prevention is probably our strongest medicine when it comes to helping prevent nicotine addiction and hopefully preventing creating long-term smokers and reducing the risk for morbidity and mortality related to smoking in general. We want to remember to congratulate abstinence and willingness to make positive changes, but really have conversations with our teens that help us understand why they're using, giving us an opportunity and for them to understand and ask questions about what the risks may be, but remembering that it's important for us to make sure that we're stressing that we advise not to use in terms of the risks associated with them, and offer support for quitting, including evaluating for dependence and treatment support. And one of probably our strongest tools is follow-up, continuing to be able to support them and move that dialogue along, especially depending on where they are in those stages of readiness. Next slide, please. So one last thing here is billing and providing resources. Again, the next slide is sort of a snapshot view of, as you're in the clinics doing these types of conversations with adolescents. If you go to the next slide, please. Luckily, you saw from Dr. Tuck's lecture earlier this morning that actually there's a move anyway towards a more time-based type of billing option for clinic visits in general, and that may very well be where a lot of your adolescent visits are, but there are specific CPT codes that you can use when you are using a validated screener for substance use or nicotine use screening. There are CPT codes that can be used to document your smoking cessation counseling. And if you're using that combination of a validated screener and more in-depth intervention or brief counseling, then that's when you are able to use CPT codes around SBIRT, which you can see some of the more typical approximate reimbursements that you can see for those types of coding. Next slide, please, are just a few resources. So resources for us, resources for our parents, and then if you go to the next slide, are resources that you can find specifically on the Ohio AAP website. So one more slide, please. This is where you'll find a lot of resources, not only for you as a provider, but even that you may be able to use in your clinics and print out for your adolescents or your families as well. So if you go to the next slide, I'm going to hand things over to Jengis. Oh, before I do that, for CME, just remember this is your special code for the 2020 annual meeting. It's prevention. So Jengis, you can take it away.
Awesome. Thank you, Dr. Dritz. All right, so let me pull this up. We can advance to the next slide, please. All right, next, please. Perfect. So before we jump in, I wanted to give background about myself and my background with smoking and vaping cessation. So I work as a clinical pharmacist embedded within a community health center here in Central Ohio. I do not work in a pharmacy. I see patients one-on-one in the office to help manage their chronic disease states collaboratively with physicians. And a main focus of ours is smoking cessation. In our initial first visit for smoking cessation, I make it clear to patients that we are on the same team and we need to work together as such. So for those meetings with patients, I encourage other clinicians, including and the approach I use, is I ask my patients to show their vape pen to me. And I don't think we should be afraid to ask them that. We need to learn about it. We need to listen to them and meet them where they're at and see how they talk about the vape pen, show you if, are they excited about it? Are they annoyed that they're using it? That type of thing as they talk through it. And in our visits, we go through extensively the three main challenges or components of addiction that make it hard to just quit cold turkey that Dr. Dritz mentioned. So that's the physical addiction, your body's actual physical dependence on the nicotine chemical, the emotional addiction and how you cope, behavioral addiction with the routine and habits. And we also have a great behavioral health staff that we collaborate with in depth for counseling for our patients. Now, let's discuss the gold standard of treatment for smoking and vaping cessation in adolescence. And that's always going to be motivational interviewing, cognitive behavioral therapy that Dr. Dritz covered. Pharmacological treatment is limited in its evidence and data in teens and adolescents, but we'll go through those trials briefly today. And then you should know that tobacco dependence pharmacotherapy can be considered for moderately to severely tobacco dependent adolescents who want to stop smoking. And tobacco cessation medication, although it's not FDA approved in patients 18 years or younger, that means that even the over-the-counter medicines like nicotine replacement therapy need a prescription from a physician or NP in order to prescribe that for someone less than 18. And regardless of the prescription, it's always best, you get the best results when combined with CBT. I think overall, you want to make sure you have a big risk-benefit discussion about next steps in adolescence. But I want to note that although I'm going to talk through all the treatments, the majority of adolescents and teens will not need medication therapy to quit. But for those that do, we'll discuss those options. Next slide, please. So Dr. Dritz showed a similar slide indicating this EDS, or the e-cigarette dependence scale. It's a 4-item questionnaire. And you may be familiar with the Fagerstrom score for nicotine dependence from tobacco cigarettes. And this is a validated scale for e-cigarettes. There's no established cutoff for what constitutes being dependent, but why it's useful and how you could find this helpful in your practice is you have them score from 0 to 4 on each question, and then you take the average of those questions, and that tells you from 0 to 4 where their dependence on nicotine lies. And although there's not if they score a 3 average, you do this, or 4 average, you do that, where that tells you on the scale that they score, it helps you figure out where you're going to dedicate your resources, time, and attention in your visits. So if someone scores very low on this, that shows that their physical dependence on the nicotine is not as big of a driver for why they vape. So in that regard, you could then be thinking of ways to tailor your visit to focus more on the emotional and behavioral aspects. So are they going through a very, very tough time that's anytime they vape, it's because of they're trying to cope with any trauma that they're experiencing? Or is it the habits of every time they're with their friends in the social atmosphere, and that's just what they do, or every time they get in the car with their friend, that type of thing. So you can start to delineate whether their physical dependence drives it, or if it's more emotional or behavioral. Sometimes it's a very, very strong component of all three, and that's completely fine. It's just you take each step with each visit. Okay, next slide, please. All right. The following slides, I'll go through the pharmacological treatment. These are meant to be informative. These are not, I'm not going to read every single word. I would not do that to you guys. I try to keep high energy, and I don't want to, I know I'm a nerd, so I enjoy this stuff, knowing everything about the medications. A big pharmacy nerd, but I want to keep it to the highlights. So this is just meant to be informational for you as takeaways. Okay, next slide, please. The first that we're going to talk about is nicotine replacement therapy, or NRT. So NRT Very, very simple within the name. I'm sure you know it just reduces the cravings and withdrawals because it simply just replaces the nicotine that's delivered by smoking a cigarette. It's supplied in the form of patches, gums, lozenges, nasal spray, and inhaler. Only the patch, gum, and nasal spray have been studied in adolescents. The nasal spray and inhaler aren't really used that often. The inhaler kind of mimics the same type of movement and habit as the vape pen, so it doesn't really make sense too much to transition someone away from that and then encourage that habit. But you can see that how you take it depends on a variety of factors, and some of them are how many cigarettes the patient smokes a day, or how much the patient smokes after waking up in the morning. So that's in the FDA labeling. Now we got to figure out, how does that translate to vaping? So Dr. Dritch's slide showed some conversion dosing based on how much nicotine is contained in the pods and how that would compare to packs of cigarettes. That's what I use, very similar scale. And so the nicotine in vape pens, as she mentioned, is a different salt form. It's much more concentrated. And so maintaining health expectations is also very important. And what I mean by that is when someone takes a puff of the vape pen, they get that peak nicotine within 5 minutes at the least. So when you're trying to help someone quit by transitioning them to gum or lozenges, they may have the expectation to get a peak satisfaction with the nicotine within 5 minutes, and that's just simply not the case. Gum and lozenges take about 20 to 30 minutes to reach the peak in the bloodstreams, but it's okay that there's a difference. You just have to communicate that with the patient and let them know. If they know ahead of time that peak won't happen, they're less likely to wait that 5 minutes, not see any benefit, then smoke the vape pen, and then 20 minutes later they get the peak from the lozenge and from their vape pen immediately, and so they attribute all of the everything that they're feeling to the vape pen, when in reality it would have worked. So keeping their mind occupied between 20 and 30 minutes for gum and lozenges until it kicks in fully is a great tactic. I think it's you want to remember that nicotine is a drug. So to give it in the form of NRT to a teenager to use as needed is something we need to consider. So does this patient have the maturity to know how to use it, PRN, and how much to use? And are they contributing, are they using it to solve the problem or to contribute to the problem? So, making sure that they have the maturity and the discernment to use it, PRN, and that gets more difficult as the younger patients get. Next slide, please. So what are the side effects? Nicotine replacement therapy is very well tolerated. It's well tolerated in adults and adolescents for the ones that were studied. The patch, local skin reactions, some sleep disturbances. If so, they can remove the patch before going to bed. Gum and lozenge, sore throat, and jaw pain. I think it's important to know that the gum and lozenge cause nausea if they're not used appropriately. I know a lot of patients, they might swallow the gum or lozenge, but after they think they got all the benefit from it. And nicotine absorbs well in the oral mucosa. It absorbs well when you inhale it and in the skin, but it does not absorb well in the stomach. So when they swallow too much of that nicotine, it's like a punching bag in their stomachs. And so dyspepsia, stomach aches, nausea, all of that happens. Nasal spray and inhaler, those are listed there. I'm not going to go through them because really not that common. Precaution, we'll talk about the precaution about those under 18. For those who have recent heart attack, abnormal heart rhythms, or worsening chest pain, that's primarily, other than the heart rhythm, in adults. Women who are pregnant and breastfeeding. So for pregnancy, you should discuss and assess the risk versus benefits about NRT. If you choose not to do NRT, we leave it up to the patient to continue smoking or vaping. And then that further introduces the harmful chemicals beyond just nicotine into the bloodstream. It affects the breathing and oxygen levels in the blood, carbon monoxide. And also, we're delivering an unpredictable dose of nicotine. So in our clinic, I have a couple of patients who are pregnant, and we do switch them over to nicotine replacement therapy after discussing with them the risk and benefits. But controlling the milligram of nicotine, the provider controlling that in the doses per day, and then us being able to appropriately taper and get rid of those other harmful ingredients is more advantageous in majority of cases and what we've seen. So if you notice, there isn't anything listed on about smoking anymore while on the nicotine replacement therapy. And so there used to be an FDA warning label many years ago that got lifted. And so they were afraid of all of the nicotine toxicity. And what they found is that there were post-marketing enough people that smoked on it and didn't have some of the severe cardiovascular issues that they anticipated with smoking while on NRT. So in my clinic, I actually like to focus on gradual reduction with patients that's realistic within the routine. And so that oftentimes starts with, we begin nicotine replacement therapy when they are not fully quit from the cigarettes. So if they're on 2 packs a day and they want to start patches, my personal preference with patients is that we at least have to make a 50% reduction in the number of cigarettes that you're used to when we start the patches. So if they're 2 packs a day, and we'll equivalent that to the pods and vaping, and you start on patches, we sometimes do a gradual reduction where they start the patches. As the patches are building up nicotine blood levels in the system over the next few days, we work on getting that cut in half, 1 pack a day, to maybe we go down by 1 cigarette a day. So 19 the next day, 18 the next day, 17. And by 20 days of being on the patches, we have gotten them smoke free. One particular reason we do that is we like to not rock the boat too much, and allow for some ability of control and get patients some small wins when they see that they can knock down from 40 to 20 or the equivalent in vaping. That's a small win, and they know they can do it, and they realize, oh, it's not that bad. And then 19 is not that much different than 20. 18 is not that much different than 19. And one thing that we do, however, is we have them prepare the next day's nicotine content the night before. So if tomorrow they're supposed to be at 19 cigarettes a day, or only 1 pod, then the night before at bedtime, they set out the next day's 19 cigarettes or the next day's pod, and they have to make that pod last the whole day, or those 19 cigarettes last the whole day, and they don't have to worry about counting what they're doing. So they don't have to count 1 and then 2 and then 3. They just know that whatever's in this pack that they prepared, they have to make last. And then it takes away the mental games that we play with ourselves with counting prospectively, other than just, hey, this is what we have, let's make it last. And it's been the gradual reduction and realistic timelines have been very helpful for patients. So the use in teens, studies have shown that NRT is well tolerated. As I mentioned, the efficacy of adolescents nicotine replacement therapy is lacking. It's not currently recommended, but the benefits may outweigh the risk, and I think logically it would make sense. I'm not sure that if we evaluate the risk versus benefits, I can understand that would prove advantageous. You can go to the next slide. This is just some examples of the nicotine products, and we'll go to the next slide again. And I'm talking fast because I sometimes get well versed in the study, so I want to leave time for that. So with bupropion, Zyban, Wellbutrin, it works in the brain. It helps the urge to smoke and or adrenaline. It works as a neuronal reaction. I got kicked off. Can you hear me, Dr. Dritz?
Yep, we can hear you now. It did actually go a little bit weird, so now it sounds good.
Okay, no worries. All right, so it comes in tablets taken once or twice a day. There's sustained release, there's extended release. I get questions from providers about whether or not you can use the XL, since the SR is the only one that's FDA approved, indicated. So they just didn't study the XL, but I've used the XL successfully. It's the same drug, a once-day formulation. The SR is 12-hour sustained release, XL is 24-hour extended release. The biggest two side effects are insomnia and dry mouth. If you have trouble sleeping, you can take, if the patient has trouble sleeping, they could take it, the second dose, 8 hours after the first dose, to be away from bedtime. You want to be cautious in people who have a prior history of seizures. It lowers the seizure threshold, history and current eating disorders, or those who recently stopped alcohol or benzos. There's a black box warning in particular for increased suicide ideation and behavior in children, adolescents, and young adults. So you want to make sure you monitor for changes in mood and suicidality. Pretty typically, if there's really not significant progress made after the 7th week of therapy, success is unlikely. And so you want to consider combination therapy or stopping it and using something else if 7 weeks isn't there. Now that's what's been studied in adults. The use of teens, there's no official recommendation for the use of teens. There's some data in particular with teens at least 14 years of age and older, who are at least 90 pounds with some success. And we will go through that on the next slide. So this next slide is it's a randomized double-blind placebo-controlled trial. It's a dosage finding trial for SR bupropion for adolescents. 312 adolescents. They were aged 14 to 17 years. They needed to smoke at least 6 cigarettes per day. And they even confirmed a certain carbon monoxide level to make sure that they were smoking a certain amount. They needed to have at least 2 previous quit attempts and no other, they excluded major psychiatric diagnoses, and also excluded patients who had a lack of motivation to quit smoking. The median age was 16, about 50%, a little over, were male, almost 75% were white race. They looked at the 150 milligrams per day, which is 75 divided by in 2 divided daily dose, 300 milligrams per day, 150 twice a day divided dosing, and then a placebo. They were about just over 100 participants in each group. And all the studies I mentioned, including this one, they also have simultaneous behavioral counseling, at least brief. They followed the subjects up for 12 weeks and then 26 weeks. They did a 7-day point prevalence abstinence with a biomarker confirmed urine cotinine. And the rates, they did that at 6 weeks and at 26 weeks. And during treatment, the confirmed point prevalence rates were significantly higher for the 300 milligram a day group than placebo at every single week except week 4. So to sum it up, the 300 milligram a day seemed the most promising in addition to the behavioral health counseling. It showed short-term efficacy, but what's important is they only did a 6-week course of treatment. So the drug was discontinued at 6 weeks. So even though they followed up at 12 and 26 weeks, I think that's important to know. So both dosages were generally well tolerated, despite having a positive end of treatment outcome. The subjects were more prone to relapsing, and I guess authors use the word relapse. I don't like that word, but they had some setbacks and continued smoking again after the 6 weeks ended. So I think we need to consider the standard that we use for adults as well. If you were to take a look at bupropion for adolescents and take it seriously, you would want to use the 12-week designation and evaluate that longer dosage regimen to be consistent with those current recommendations, so that we allow us more time over that 12-week period to be working on the behavioral and emotional sides of the addiction, so that when we do stop the medication treatment, they're well prepared. There's another study that I didn't include. It's a few years later in 2011, just looked at bupropion in addition to contingency management, which is a form of CBT and behavioral counseling where they incentivize patients to quit. And the contingency management with the bupropion was better than any of the other choices alone. All right, next, please. So Chantix or varenicline, it's a partial agonist at the same neuronal receptor that nicotine occupies. So it prevents the stimulation of dopamine pathway that's associated with nicotine addiction. And although varenicline doesn't stimulate, or it does stimulate dopamine activity, it does it at a lower potency. So to a much smaller degree than what nicotine does. And so we have the decreased craving and withdrawal symptoms. So there's a little bit higher affinity, lower potency. The way I describe it to my patients is, I say, what if this room was full of chairs? And I usually do this in person, but if the room was full of chairs and every chair was a nicotine receptor, and nicotine would come in, sit on the chair, and the chair would feel satisfied and full, right? Because there's nicotine sitting in the chair. The way Chantix works is it comes in to the room and tries to hug the chairs. So it doesn't sit in the chair and put its weight on the chair, but it hugs the chair. So the chair feels satisfied, and when nicotine comes into the room to sit down, it can't because the chair is occupied by Chantix that's hugging it. So it's a little bit of a stretch of a metaphor with a virtual environment without being able to show that to you guys and how I would explain it in person with patients. But I think it gives them an idea of what it does, because there's so many misconceptions with how Chantix works, especially with some of the extreme things we've heard, as I'll touch on. So it is effective at relieving and cravings and withdrawal symptoms during abstinence and blocking the reinforcing effects of smoking. So much to a point that in May of this year, actually, the ATS guidelines updated and said that they recommend Chantix over bupropion, recommend Chantix over nicotine replacement therapy as first-line options. They even said that you should be confident with prescribing Chantix, even if patients are not ready to quit, but have increased their want to quit. They suggested starting Chantix. So if you have some time, you want to look at those guidelines, it's pretty interesting how they changed that, just because of the way that Chantix works. So when it occupies those receptors, I've had patients say, they smoke or vape and they don't feel the same satisfaction from that puff. And so that's great that nicotine or that Chantix works like that for so many. Comes in tablets twice daily. You titrate it gradually and minimize side effects. Most common side effects: unusual vivid dreams. I also do the recommendation for 8 hours after the first to help alleviate some of those vivid dreams, and it's worked, especially with insomnia. The nausea is dose dependent. I've had patients that couldn't tolerate the optimal dose, and we still backed them down and saw some benefit at the moderate dose. One thing I do want to touch briefly on is the neuropsychiatric comment on the slide, the behavioral changes, irritability, precautions for depression, suicide. So there was a post-marketing, some post-marketing requirements in the United States that require 2 drug manufacturers to investigate the risk. And they looked at patients smoking at least 10 cigarettes a day, and they needed at least moderate nicotine dependence, who had a variety of psychiatric conditions, but were considered stable. And I included a snapshot of the study. It's called the Eagles trial. It's towards the end. It's just there for your reference. But the psych conditions that were evaluated were mood, anxiety, psychotic, and borderline personality disorders. And it included schizophrenia and PTSD. And also, I think, bipolar as well. So what they found is that for the patients who were clinically stable, There were no concerns noted, no treatment emergent adverse effects related to neuropsychiatric category. So they define clinically stable as no exacerbation in the last 6 months and on stable treatment for at least 3 months with no treatment change anticipated during the study period, which for them was 12 weeks. So that study's there if you want to look at it, get a better idea, and to help you feel a little bit more confident in any of those scenarios. There's usually two sides of the awareness of this drug that I find with patients or parents of patients. The first extreme is they love it and they want to try it. They don't want to try anything else because they had a cousin who started it and was so successful, and yada yada yada. They love it. Or they, on the flip side, they saw a commercial and read on the internet, and so they're afraid of it and want nothing to do with it. They've heard all these bad things, So I really don't see too many people in the middle. It's usually on the either side. So having the arsenal of the trials to help reassure people, I think, is important. It also lowers the seizure threshold. So be cautious in those who have heavy alcohol use or have a history of seizure disorder, because it can intensify those effects of alcohol. Insufficient data on any use in pregnancy or breastfeeding. It's not recommended in teens that are 16 or under. There's some evidence that we'll go through about those less than 17. So next slide, please. The first trial was in 2019 that I'll go through. It looked at the efficacy and safety of varenicline for adolescents. It was 2 groups. They were randomized in 1-to-1 ratio, placebo-controlled, double-blind. They went through the full intent to treat, so not just those who kept per protocol. It was in Charleston, South Carolina. They used self-reporting smoking data, but also confirmed with biomarkers, which was nice, and helped minimize that limitation. It was ages 14 to 21 who smoked daily for at least 6 months, at least had 1 failed quit attempt, but were actively seeking to quit. They excluded any history of psych issues, any pregnancy and breastfeeding, or simultaneous use of any other drugs that are used for smoking cessation. It was 157 patients. The average age was 19, so a little bit higher than what we would want for teen and adolescent study. 60% male, 76% white race. So it was study drug, varenicline versus placebo, and they embedded that counseling. One thing to note in this study and the next one I'll touch on, they chose different doses based on kilogram of weight. So 55 kilograms and below, they chose to titrate at to stop the titration at the 0.5 milligrams twice a day, and then continue at that dose. But for those patients who were at least 55 or were over 55 kilograms, they continued the titration to the 1 milligram twice a day thereafter. The primary efficacy endpoint at the end of week 12 for abstinence was the same in both groups, 8.9%. There were some significant findings in the secondary endpoints, but when you don't find any significance in the primary endpoints, you take a lot of the secondary endpoints with a grain of salt, maybe looking at areas for future study, but can't rely on that clinically for any type of confident use. So they noted it was well tolerated, even though they had no treatment emergent adverse effects, including neuropsych adverse effects, but they had the exclusion criteria against any psych inclusion. And they made some conclusions based on the secondary outcomes, but I'm not going to go into that because, again, they didn't find that primary outcome. The next study was high and low dose varenicline, divided the same way that I mentioned. Adolescent smokers aged 12 to 19. It was across 57 outpatient centers, USA, Russia, Canada, Taiwan. And they followed up patients patients received the ratio versus placebo for at least 12 weeks. And they followed up for an additional 40 weeks to look at the outcomes. The trial didn't show any advantage in abstinence with varenicline compared to placebo. The treatment emergent adverse effects were similar between the previous trials of adult smokers, so there was nothing new for tolerability. But the findings didn't really support the use of Chantix as first line for adolescents. The authors gave some speculation as to why, and I'll finish up here in just a minute. because adolescents place a high value on peer affiliation, like Madeline Ivy had talked about, that peer affiliation and approval, and are exposed to positively framed influential media images of smoking, as Dr. Dritz mentioned. The authors said that, even if a medication was precisely targeted that desired neuropharmacological pathway for smoking cessation, the counterweight of the psychosocial factors that are commonly faced by adolescents in support of smoking and vaping might have offset the potential benefit of the medication. So we can move on to the next slide. Next slide should be just a snapshot of the Eagles trial for your reference. I hope this was helpful. We have a list of all the references there on that slide. And in the interest of time and to leave time for any questions, I'll stop there. I could talk for hours, so I'll hold it off there. But Dr. Dritz, I'll turn it back to you. Thank you guys for your time and attention.
Great, thank you so much. So next slide, I know we are at our 12:15 mark. I want to thank all of our speakers, Jengis and Madeline and Ivy, for lending us their expertise during today's presentation. I want to thank all of you for what you do in the clinics, especially as you help support adolescents. Really in helping promote those positive behaviors, prevent vaping use, and really help them get through those really difficult addiction that we can see with nicotine. If there are any questions, I haven't seen any in the chat box, but if there are any questions that come up, feel free to send the questions to the Ohio AAP. You please remember to go online to do your evaluations for today's visit and to get your MOC Part 2 credit form filled out. And I think that is it. Thank you again for attending, and everyone have a